BioBalance Healthcast, episode 93, Early Menopause and Heart Disease.
BioBalance Healthcast features conversations about positive aging, covering treatment and solutions that include bioidentical hormone pellet therapy, safe and affordable skin rejuvenation, and spa-quality botanical skincare. Your hosts are Dr. Kathy Maupin, Medical Director of BioBalance Health and a leading expert in treating symptoms of aging, and Brett Newcomb, a licensed professional counselor.
Welcome back. We're going to be talking about early menopause and heart disease. There's been some new research done, and the American Medical Association has sent out a notice to doctors, and part of the notice discussed women who go through menopause early have an increased percentage chance of having either strokes or heart disease. And so we want to talk about what's involved in that, what they know and what they don't know, what the research is beginning to look at.
Well, we've always thought that estrogen lowered cholesterol. Estrogen does lower generally the total cholesterol and increases the good cholesterol, HDL. So we've always known that, but we've never had a study before that looked at women who had menopause early, and they said early was 46.
Yes.
So
actually, let me quote what the pair.
Okay.
It says, women who go through menopause before age 46 are twice as likely to have a heart attack or a stroke as women who hit menopause later. And this is reported in Reuters Health, and it's reported in the AMA.
And I believe that this is not just an estrogen issue, but estrogen plays a part. Estrogen does protect us from the cholesterol issue. It does help us with keeping our inflammatory reactions down. And inflammation plus high cholesterol equals heart disease. But there are some other things that they didn't look at that affect early menopause. Some women have genetically early menopause. Some women have an antibody that kills their ovaries, and that antibody is an autoimmune type disease. So if you have an autoimmune type disease, you're also higher inflammatory risk, higher heart disease risk. So that can cause early menopause. Smoking can cause early menopause. And we know that smoking causes heart disease as well. So when we have smoking and early menopause, was it the smoking or was it the early menopause that actually caused the higher rate of heart disease? Because that's a lot, twice the amount of heart disease if you have menopause or even if you have your ovaries removed.
Well, yeah, that's what I was going to say, because it's not just people that went through menopause,
right.
It's women that had hysterectomies as
right.
well.
Right, but they didn't sort those out.
No, they're
all
they
together
have,
in one group. So is it the cause of the early menopause, or is it the loss of estrogen? And I contend it's also the loss of testosterone. Because if you go through early menopause, you also go through an early loss of testosterone, which I call testosterone deprivation syndrome, which is early low testosterone. And testosterone protects us because it's an anti-inflammatory,
right,
and it lowers total cholesterol level. And in those ways, it prevents us from collecting atherosclerosis on our vessels.
So why is this important? If the study says alert women who go through menopause early, and they actually have a significant number of women in various genetic groupings as well. So they can say Oriental women or black women or white Caucasian women all have increased risk, but slightly different in each category. So that's the alert.
But they don't give us a good answer.
They don't give us, and they say that
scaring people with no answer is not really good for us to hear, because as doctors or as patients, because then fear is a terrible thing to carry around with you. Anxiety.
Well, it's like
is
saying
a
your
risk.
faucet's leaking, but we don't know where yet,
And we
or we don't
can't
know
fix
how
it.
much, and we don't know how to fix it. But you need to know your faucet's leaking.
But the reason we're talking about this is that
Yeah.
there are other studies, thankfully,
Yes.
who have looked at risk of heart disease and giving back estrogen and testosterone, or both. And we found that when we replace estrogen and or estrogen plus testosterone, we decrease the cardiac risk and the risk of having a stroke. So in those cases, we know that the risk is associated with estrogen, not just the cause of early menopause, and it is actually effective to replace those hormones in a non-oral fashion, in a way that's like patches, gels, vaginal tabs, something like that, that is safest, or pellets like what I do in my practice.
Right.
So those are the safest ways to do it. Now, WHI study, we've talked about this before, came in and said, oh, estrogen's bad, everybody should go off of it. And they said it increased heart disease, which is not true, because they then extended their study for 10 years. And they looked at the women who had replaced their estrogen alone, and they found that those women had less heart disease than women who had nothing at all. So it is effective in many other studies to replace your estrogen so that you're not just panicked by this headline. And so you do have an answer. Your answer is replace your estrogen, and if you can, replace your testosterone. And that will help protect you from heart disease. Also, I want you to know that obesity is the worst thing you could have for heart disease. You have to control what you eat. Yeah. You have to exercise. You have to stop
your
smoking.
Your heart muscle's having to push all that weight uphill every time you breathe, every time you move, every time you roll over. So even if you're sedentary and obese, your heart is working super hard.
Because your body's much bigger. It has to pump blood everywhere. The larger the surface area, the harder your body has to, or your heart has to work.
Right.
Everything else in your body does too.
Well, and you want to put it in perspective, because there's an art to headline writing. Newspapers and magazines hire people to write headlines that'll get people's attention. But there are a number of studies that show people get most of their interpretive understanding just from reading the headline.
Right, and you have to think farther than that.
So when
I don't want you to just read the headline and freak out. That's just not productive.
Exactly. And so when they say you're twice as likely to have a heart attack if you go through menopause early, you need to look deeper in the article or deeper in the research. And what it says is there's in this study, which had 3,000 women in multiple genetic groupings, 1.5, none of them had heart disease risk at the beginning. And by the end of the study, 1.5% of the women who had not gone through menopause early, which is 51, before 51, that's the average in America, had heart disease or stroke issues, and 3.3% of the women who had gone through before 46 had heart disease or stroke issues. So we're still talking about a really small risk level. So when you see the headline that says, oh my God, you're twice as likely to have a stroke, don't have a stroke.
Don't raise your blood pressure because of that.
Go, oh crap.
Because there are things you can do, and honestly, I have patients.
Yeah.
I love my patients, and they give me the most satisfaction. I love going to the office because they give me all this information about them, and also their reactions to what I tell them help me with the next patient, and that's what they call it, the practice of medicine. But I have patients that come in and go, oh, I'm not taking estrogen. It's going to cause heart disease. And I say, well then, if you really want to change your risk, stop smoking. Start walking every day.
No, that's ridiculous. You always say that.
Stop eating carbohydrates. Start eating fresh vegetables and lean meats. And they look at me and they go, well, I can't do all that.
Right.
And I said, well, not taking estrogen is not going to help. You need to take estrogen, and you need to do all these other things.
They say, I don't believe in drugs. Give me a beer and a cigarette.
Yeah, that's true. Sadly, that's true. So if that's you, hear me. Not taking estrogen is not the answer if you are a smoker and your BMI is over 29. And I mean, if you don't go exercise daily, if you don't run the steps and park your car farther away from the front door so that you can walk more, if you don't do those things and actually maybe work out every day, God forbid, then that increases your risk of heart disease. Think about that when you're going into the middle of the grocery store. That's where all the danger is. Stay on the outside. That's all the fresh fruit, vegetables, and some milk products are good, and some things that you can eat, your family can eat, and you will not gain weight from just sitting in front of the TV and putting it in your mouth. Right. I mean, put grapes in your mouth. Don't put Doritos in your mouth. I mean, that's so simple.
Yeah.
And it's something that we have to do, and we've learned to do because I am naturally not lean. I mean, it takes a lot of work to stay lean, and the older
You know,
you get, the harder it is.
It's such a complex problem to solve. I've done over the years a lot of work with men who've gone through divorces at middle age, either ones they wanted or ones that they were surprised by. And depression is a common result of that. And most people, many people, I think most people when they're depressed tend to eat more, but they eat to fill that emotional emptiness, and they're not really aware of what they're eating.
Yeah.
And so we talk about behavioral tricks that you can use to avoid compounding the problem of your depression. And I would talk to men about, do not live in a cave. Don't just have, a couch that you live and sleep on in front of a TV and eat all your meals there. Make yourself go to a table, set a formal place setting, sit down and eat a meal, turn off the television, turn off the radio, don't read a book, be conscious of the food that you're consuming.
It's really hard to do that by yourself.
It is so hard to do, but it's worth the payoff. I mean, it's like exercise is hard to do. There are things that you can do to mitigate these circumstances if they're circumstances that you're dealing with. But part of why we're having this conversation today, and it's so wide-ranging, is a headline like this. This is in a journal that goes out to doctors of all trainings and persuasions.
I get mine by email
an email
every
bulletin.
day.
Here's,
every day I get
here's
these.
a headline. And a lot of physicians, especially GPs, are not current on the whole question and the research about hormone replacement therapy for
And that's
women.
because God knows they have enough to do. Okay?
Yeah, I don't mean that as a
realize
criticism.
That's why I like to educate
But
patients.
when we talk about, in the social sciences, one of the things you're trained to look at is who said it, what research did they use, how did they phrase it, what do the statistics say? Because we are trained that figures never lie, but liars always figure. So
or produce
statistics. It can be expanded or contracted to emphasize the point you want to emphasize. So you have to read it objectively and critically. And so when you read this report further, what it says is that the original research that they were doing, they canceled the question, looking into the question of hormone replacement because of the WHI study.
Right. They didn't even complete their study because WHI came out and they stopped replacing people's estrogen.
Yeah.
And only because that study came out. But if I read the study when it came out, and it made no sense.
Right.
Because I looked at what people were in the study, what their average age was, which was way too old, what their average weight was, which was way too high. They started people who'd never been on hormones late in their menopausal age. The average age was 69. And that means there was a bunch of 85-year-olds started on it who have never taken estrogen, and as well as the 40-year-olds. So that the segment of the population they were studying was wrong, and their conclusions were wrong because it was just Provera. Provera, the one drug, Provera, is a progestin. It was clear in the first study when I read it that it was the estrogen progestin patients that had higher rates of heart disease and breast cancer, not the estrogen-only patients. So it wasn't that headline
so the variable
that
that needed to be studied was the progestin,
and
not
they still
the estrogen.
haven't studied that.
Right.
I mean, you need progesterone if you have a uterus. You just don't need Provera.
So if you go and you look up this article, when I read it first, I said, well, Kathy, they're saying that they don't know if hormone replacement will help these women avoid this cardiovascular risk. And that's what this reports.
Well,
and then doctors that don't know what you know, that don't know the studies that you have read, that are later than the WHI study, will read that, just as patients will, and say, oh, then I shouldn't consider hormone replacement. That won't affect this particular risk factor.
The other thing is they did come out with a couple other studies in the past 2 weeks that said that you have to individualize both care for people for heart disease. I mean, individualize, and that's what medicine is. Medicine is not a bunch of guidelines, and we give you all of these lists, and then you're supposed to go pick out what you're supposed to do. It's individualized care. That's what it's supposed to be. It's not supposed to be we all go eat out of the same trough. It's supposed to be someone brings you a perfect meal, and that's the meal that's good for you. And so that's what these two studies, one on hormones, one on heart disease, not interchangeable. They weren't looking at hormones and heart disease.
Right.
They were just looking at them separately, and they said it has to be individualized. You can't look at a headline and decide what you're going to do with all your patients.
Well, and the simplest rule on that is to remember the leading cause of death among research of rats in research is research.
Oh yeah, I didn't know that.
I'll say that more clearly. The leading cause of death in laboratory rats. Is research.
Right.
So you need somebody that has the information, can assimilate it, and then relate it to you as an individual. And that is why in our podcast we emphasize almost every week the importance of being an informed consumer. You need to educate yourself. A little bit of not learning is a dangerous thing, and you need to be able to go to your physician and say, I have questions, I'd like to talk to you, let's look at my information, explain this to me, and what are the risks if I do follow this treatment or get this treatment, and what are the risks if I don't?
Which is the most important piece of information. Yes. Yesterday I was talking to a patient who has a pre-breast cancer, okay? It's a carcinoma in situ. It has gone nowhere. It's right in this little tiny little area.
Right.
And she's been my patient since forever. And so she's been getting mammograms every 6 months because they keep finding all of these little things. And
are there cysts or shadows?
They're a duct. The breast is like one big sweat gland, believe it or not. Sorry, guys. It's a big sweat gland. And all of the ducts come out. It's like from the nipple, all these ducts are coming toward the nipple, and the ducts themselves are like little tunnels, and they can get a cancer inside that duct. So it's kind of protected because it's within this duct. She had 2 different kinds of ductal cancer, and not cancer, precancer. So she had them biopsied. She had other ones biopsied last year and the year after that, before that. So here we are, 3 years in a row she's had biopsies. She's got scars all over her breast. Yeah. She almost has no breast left. And the answer to this from her physician is, and she has great physicians, is let's do radiation. She doesn't have cancer. Let's do radiation. And then you probably won't have to have these biopsies all the time. Now, what I advised her to do was ask the physician what the risk of radiation is, because the risks of radiation are high. And they can lead to cancers of other types later. And they totally, in general, now it's not always, deform the breast itself. So
radiation can.
Yes. Okay. So my advice would be to her, in her circumstance, I'm not saying this to people who have overt breast cancer necessarily. It depends on the situation. But in this particular
Which is your whole
case,
point.
My point is it has to be individualized. And she didn't ask her doctor, what are the risks of radiation? Because she thought the risks of removal of all the breast tissue and replacement with implants would be higher than radiation, but it isn't. When you look at both risks, the risk of taking the breast tissue out and putting in implants instead, she won't have to worry about biopsies or anything anymore. But once you do radiation, it's very hard to put in an implant because the skin doesn't stretch anymore. So this is all about individualized care and the patient asking the right question. The doctor may have been in surgery or may be a little distracted and tell you what she thinks you should do, but you have to ask, well, what are the risks?
You also have, you weren't in the conversation, so you don't know.
I don't know.
It's so important to be aware of how you think, especially if you're delivering critical information. How's the person hearing it? Because we tend to hear the things that scare us. We tend to hear the negatives. I remember for years I've done large group presentations, and they always do evaluations, and so you get forms back, and people have very kind things to say generally, but there's always 1 or 2 people that say this was boring, this was a waste of time, you're a complete idiot. Those are the only ones I hear. Those are the only ones. And so if you say cancer, it really affects people's ability to hear. They become frightened. They're convinced that a cancer diagnosis is a death sentence. And the survival rates for cancers of all kinds
are excellent
have
now.
Just gotten so much better over the last 15 years. And most people don't die from cancer now.
That's right.
I mean, people still do, but most people don't. But when you tell me cancer, I shut down.
That's
I
right.
panic. And if you're busy or preoccupied or building to a point that you haven't gotten to yet, and I quit listening because I got scared,
That's true.
you need to be aware of that. And that again comes back to the skill of the physician, the focusing attention of the physician, and the practice of medicine as a skill, not just the science of medicine.
It also takes time.
You don't want your doctor to just be a talking head.
That's right. You need to have them listen to you and you listen to them as well.
Yeah.
I always suggest bringing in someone from your family with you who can take notes while you're listening, and then you two can talk about it afterwards.
Yeah.
I don't even mind somebody bringing in a tape recorder. If they think if they can't bring someone with them, then ask if you can use a tape recorder, because the studies say that patients only hear 20% of what you say.
I had people tape
That would cut my
record
day short
therapy
if I just said
sessions a
20.
lot of times for that reason. They'd say,
Yeah.
I need to go home and listen to this session again. I need to hear it 3 or 4 times because I can't absorb what we're saying.
So those are good ideas to overcome the rush there is in medicine. But the one question you must always ask is, what's the risk of this versus this? Or how much gain will I get from it? Someone else had breast cancer and they said, you need chemotherapy. And she said, well, she came back and told me she was very proud of herself. And she said, well, what's the percentage of my survival if I take chemotherapy? What's the percentage if I don't? It increased her survival rate by 1%.
Yeah.
1% is not much.
Yeah. And why do I go through all of
and then the risk of chemotherapy is high.
Yeah.
So then there's risk for that. So in that way, she was very proud of herself because she had asked the right question.
Right.
And she had gotten the answer that she could then formulate, talk to her husband about, make a decision. And so she made the decision to not do the chemotherapy and to do something else.
Remember, though, if we were talking about how people hear selectively and they get frightened by certain things, and so if the doctor says cancer and you freeze, if you say tape recorder, the doctor will freeze because they're going to think that you're going to want to sue them.
Yeah,
and so
some doctors
you need to say, this is about me and this is about that. And again, it goes to the quality of the relationship. If your doctor has time to talk to you, if they know you, if you have a relationship with them and you're comfortable, then you can say that, and they're not going to panic. They're not going to go, why, and become extremely cautious.
And the last thing I have to say is, a lot of times when I was in OBGYN practice, I had more time than most doctors allowed for patients, but I didn't have an hour.
Right.
I had 20 minutes, and usually people are booked like 7 to 8 minutes apart, which is difficult at best. But I used handouts. And when I've spent the time to give you a handout with risk-benefit ratios on it, and for you to look at it, and for me to hand it to you and circle things and say, read those things, or just say, read this handout, or read it before you come to see me, I think you should do that.
Yeah.
I mean, I think that you should. The doctor's trying to give you better care.
Well, you have all that on your website now. People that want to come see you can download that and read that. They can watch the podcast. They can do all of that before they come in and sit down.
And it's awesome because they come in and they go, oh, I've listened to all the podcasts. I've read your website. I've looked up all the articles. Just give me my testosterone. I'm like, no. We have to talk about you. We can't just go by all that. We have to take all of this.
They come in and say, I've only got 7 minutes.
I've got 7, yeah. And I'm like, well, I've got 45 minutes scheduled, so you're going to have to sit here for 45 minutes before you get your hormones.
Let's talk.
So let's talk about this. Yeah. So that worries me as much as people who, just don't get what I'm saying. So, I want to make your care perfect for you.
The podcast we did a couple of weeks ago about the importance of attending in the conversation. I remember the example you used was a cartoon that was in the paper where all of the patients and the doctors were focused on the computer screen, and nobody was paying attention to each other.
Right, or to the patient.
Yeah. So you want to get back to, if you can possibly get back to, a situation where you can have a conversation with your physician, and they can attend to you, and you want to ask the questions. And one of the questions you want to ask is, what's the risk if I do? And what's the risk if I don't? And how do we find out? So thank you for listening.
We'll see you next week.
Email your questions or comments to podcast@biobalancehealth.com. You can find the BioBalance Healthcast on iTunes and on YouTube. For more information about bioidentical hormone pellet therapy and other reverse aging solutions, visit biobalancehealth.com or call 314-993-0963. Follow Dr. Maupin on Twitter @Dr. Kathy Maupin and on Facebook at facebook.com/biobalancehealth. Brett Newcomb can be found at brettnewcomb.com.